Taking you to the American Cancer Society's National Conference on Cancer of the Colon and Rectum, this is Audio Digest Surgery, Volume 18, Number 13, the first of a two-part program highlighting sessions on management of colon and rectal cancer and polyps. To start things right off, here is the program chairman for the first day session, Warren H. Cole of the University of Illinois College of Medicine.
The first part of our program is the panel on polyps, and the moderator of this panel, Claude Welch. Dr. Welch.
A few years ago, there might have been a tremendous amount of disagreement on a panel such as this. The committee in charge apparently took it very seriously and thought we'd better come up with a unified concept, so I noticed that they've picked two men from the same area who have already agreed on the fact that there is only one proper viewpoint on polyps, and they've been able to persuade most of the country that this is so. Dr. Ackerman and Dr. Spratt, as most of you know, were co-authors with Dr. Moyer on the famous paper which overturned many of our previous concepts of polyps. It therefore is very fine for us all to see the two of them on the platform as well as the two other men who will be with them. First part will be carried on by the pathologists, and first Dr. Loren Ackerman will speak to you about the simple adenomas and consider the malignant potential of these particular lesions. Dr. Ackerman.
I think it's important to recognize the different types of epithelial polyps in order to tell whether or not they have any malignant potential. The Poitt-Jaeger polyp is a very rare polyp, and it's rarely associated with cancer. The hyperplastic polyp, which has been well described by Lane, is usually small, inflammatory lesion, and is non-neoplastic in its potential. The retention polyp, usually occurring in children, is probably not a true neoplasm. Has no malignant potential. Patients have massive bleeding and at times into susception. And in adults, when it occurs, errors occur when they are multiple and thought to be polyposis. The villus tumor is an entirely different lesion. It's an epithelial lesion which microscopically has a very characteristic appearance which at times can be recognized on biopsy and radiographically. It's usually single. I believe it's probably somewhat like the transitional cell cancers of the bladder. It has the same growth rate as shown on measured X-rays as a cancer. It's associated in a high percentage of instances with invasive cancer. And it can implant in the soft tissues if you have a surgeon who carefully places a piece of it there. The adenomatous polyp is a very common lesion, at least in the United States. And frequently on its surface, there are changes which in the past were overestimated, and often these lesions were called cancer. And these are just epithelial atypias. I suppose that many lengths of bowel were removed incorrectly on an overcall of a lesion. Now, polyps are common, and it is still our feeling that very few, if any of these, eventuate into cancer. Probably the stimulation for the bowel epithelium to make adenomatous polyps or cancer is the same, but perhaps, as in the experimental animal in the rats, it's a Y relationship in which the lesion either becomes benign adenomatous polyp or becomes a cancer. And if your racket is to remove polyps in an effort to prevent cancer, to some extent this may be a remunerative procedure, but it may not prevent too many cancers, because you have to remove, in this age bracket of 30, 4,000 polyps to get one cancer. And this decreases with age. But still, that's an awful lot of polyps to have to remove to get one cancer. In other words, you're doing your examinations to find cancer, not polyps. And in very few instances in cancers do you see any remnant of a pre-existing adenomatous polyp. Now, I think if you see the usual cancer, which hasn't really changed much in size from the standpoint of detection, it's a very well delimited cancer with a central ulceration, and the borderline between the cancer and the normal mucosa is sharp. Now, there's a very sharp break there. Now, these cancers are large, and therefore any evidence of an adenomatous polyp might be obliterated by sectioning them. However, if you sectioned a polypoid cancer or any small cancer, practically never will you see any evidence of a pre-existing tumor. Polypoid lesions with stalks that have nothing in the stalk don't have to have anything further done than the removal of the lesion. Plaque-like small cancers may occur, and I think in many instances the eventuation is a very direct one. It is cancer from the beginning. Adenomatous polyps are pretty well distributed throughout the colon, where cancer occurs at both ends. And I think most important that the frequency of cancer found by, say, repeated examinations, proctoscopic, etc., conforms to the expected incidence without relying on the polyp cancer sequence. I'm also of the feeling that development of both polyps and cancer is probably on an environmental rather than a genetic basis. And I think the most important part of our symposium here is how to handle these polypoid lesions when they're found either through the proctoscope or by barium enema.
Well, now next we have with us Dr. Horn, who is the chairman of the Department of Pathology in the Henry Ford Hospital of Detroit. Dr. Horn will concentrate upon the more dangerous of this pair of polyps, the villus adenoma. Dr. Horn.
First, I'd just like to define terms a little bit, not that I'm going to try to give you basic lessons in histopathology, but just so that we're all talking about the same thing. An adenomatous polyp is a nodule composed of what we interpret as neoplastic glands on a stalk of normal mucous membrane. The characteristic glands of the adenomatous polyp with crowded cells, elongated hyperchromatic nuclei, and frequently a lack of mucin secretion. The papillary adenoma, on the other hand, is characteristically a superficial growth of these fronds of the surface epithelium forming complex branching papillary structures. Mucin secretion is a feature of this lesion. The hyperplastic polyp, as has already been pointed out, probably has no significance as far as the later development of cancer is concerned, although it does have certain things in common with the villus adenoma, and some people have suggested a relationship. It does show a very intense mucin secretion. I reviewed the polypoid lesions of the colon, which were diagnosed over a recent 5-year period in our laboratory, to see the types of lesions: adenomatous polyp, hyperplastic, the papillary adenoma, the mucosal polyp. And by mucosal polyp, I've simply meant what looks like a polyp to the surgeon, but which is just a simple projection covered by a normal mucous membrane to the pathologist who looks at it microscopically. The inflammatory polyp, there were 2 polypoid carcinomas with no evidence of an associated benign lesion in this group. 2 cases of familial polyposis and 47 other polyps. As a matter of interest only, 16 of these others were carcinoids, 14 myomas, and 10 lipomas. Now, to review the papillary adenomas, I went back to a slightly earlier era, simply so that I would have some period of time in which to follow up these patients. And here again, the lesions are primarily rectal. A slight majority measured more than 2 centimeters in their smallest diameter. I thought perhaps the size might make some difference. The reason the break came at the 2 centimeter mark is because that's the way it was convenient with the material. The symptoms, too, I've listed according to the size of the lesions. Slightly over half of the larger group were symptomatic, usually with bleeding, but actually the difference between the 55 symptomatic larger ones and the 41 symptomatic smaller ones is not very great. The patients with diarrhea, none of them had electrolyte studies nor symptoms suggesting an electrolyte imbalance. 28 of the total lesions had another epithelial polypoid lesion associated with them at one time or another. These were usually, but not always, adenomatous polyps, and the associated lesions were divided about equally between those that occurred before the papillary adenoma was diagnosed, those with it, and those that occurred subsequently. Obviously, the most important thing about the papillary adenoma is what happened to these patients. There were only three local recurrences in the group. One occurred at 1 year, and the patient is still surviving 6 years later. One occurred 6 years after original treatment, and that patient is surviving after a re-excision, although it is only a short time. The third patient had 2 recurrences at 1 and 2 years, and then an abdominal perineal, and now is alive and well after another 5-year period. I might say that all of these patients with recurrence had initial treatment by either piecemeal biting away with the forceps and or electrocoagulation. These are the end results of 76 patients on whom I had follow-up. The living patients, I should say, were all followed at least 2 years, and of the 61 surviving, 42 have been followed more than 5. 2 patients alive with the disease, 2 are dead of carcinoma, 1 presumably of another carcinoma, not of carcinoma developing in the papillary adenoma. And 11 are pretty definitely unrelated to the papillary adenoma or carcinoma developing in it. The cases in which the diagnosis of carcinoma in a papillary adenoma was made, and our percentage is considerably smaller than most of those reported. They've been reported as having cancer in them in from 10 to 55%, and our percentage works out about 6%. From this small, modest study, the papillary adenoma doesn't look as evil as it has been painted by many people. Its role as a precursor of cancer, it suggests perhaps, is no greater than that of the adenomatous polyp. The fact remains that a significant number, however, do have cancer in them, and one cannot tell whether cancer is there or whether it is not without its removal and pathologic examination. I don't have enough material here to say very much about treatment, but what is suggested, and it supports other studies, is that if at all possible, treatment should be by complete removal, and that it is very difficult to be sure of complete removal by any of the piecemeal or electrocoagulation processes.
May I comment that you've had a very good group of patients with papillary adenomas or villus adenomas. As I was asking Dr. Ackerman what his percentage of patients with cancer in these lesions happened to be, he thought about 40%. In our own hospital at the MGH, I've estimated 30%, and Dr. Castleman, who's notoriously moderate in his views, estimates 15 to 20%. These are all far above the 6% that you've noted from the hospitals in Detroit. So we'll be very interested to hear what Dr. Miller has to say about this matter, because he will give us a complete overview of the thoughts that he has about how these lesions, which are indeterminate before they reach the pathologist or before they reach the hands of the surgeon, should be analyzed and treated. Dr. Miller.
A basic science colleague of mine once gave me a good piece of advice. He said that if one wished to choose a potentially significant research project, take a dictum that has been around in medicine for at least 10 years and restudy it. It will almost inevitably be found to be at least partially wrong. So it is, I think, with the so-called polyp carcinoma sequence upon which so much of the rationale for management is based. Our own data at the Hospital University of Pennsylvania does not confirm this chronologic progression. The average age of our patients with adenomatous polyp with focal invasive carcinoma, and with frank cancer are almost identical, 59, 62, and 60 years respectively. The average age argument at best has never been very compelling. There seems to be virtually universal agreement that carcinomas of the colon are associated with benign adenomatous polyps in a high percentage of cases. In our own series, for example, the figure was 23%. In addition, In our study of multiple colon cancer, 59% of the patients with synchronous lesions and 60% of the metachronous group had associated polyps, either before or concurrent with operation. Looking at these data from another vantage point, of 90 patients with colon cancer and associated multiple polyps, 15% had a synchronous lesion, and 12% developed a second or third lesion subsequently. Of the 110 patients with colon cancer and one associated polyp, 7% had at least one other frank cancer, and 2% developed at least one other carcinoma at another point in time. In addition, it was remarkable to us in analyzing our cases that when focal invasive carcinoma was discovered in an adenomatous polyp, other benign polyps were associated in 48%, and a separate frank garden variety carcinoma of the colon was found in 20%. Of the 81 villus adenomas, 20% were associated with one other tumor, the vast majority a separate frank carcinoma. I bombard you with these statistics to make the point that whether benign adenomas become malignant with time or are malignant from their onset, the colon that harbors a neoplasm, benign or malignant, is more likely to be fertile soil for other tumors, both benign and malignant. It is a neoplasm-prone colon and should be assiduously watched by appropriate diagnostic techniques with this in mind. The basic clinical problem, in large measure, does not depend on whether one believes that benign adenomas become malignant or are malignant from their inception, or on whether small carcinoma-like areas in adenomatous polyps may eventually result in the death of the patient. The clinical problem is what to do with a round, regular defect of sufficient size on a barium enema or a polyp study. We have identified 33 lesions in our series that all clinical observers, the surgeon through the proctoscope and/or the radiologist, thought were benign lesions, but which on pathologic examination were all cancer. In contrast, some lesions have all the size and irregularity suggestive of a villus adenoma or a polypoid carcinoma, and prove to be entirely benign adenomatous polyps. Therefore, until the radiologist develops the diagnostic acuity of the pathologist, the approach to these lesions will be in the hands of the surgeon, almost irrespective of which side one takes in the great polyp debate. The malignant potential of the villus adenoma has not been seriously contested. On review, several lesions previously diagnosed as adenomatous polyp were in fact villus in nature by modern criteria. This was particularly true of the larger polyps, where mixed villus and adenomatous features were apparent. Increasing recognition of this phenomenon is appearing in the literature. The villus adenoma per se tends to occur almost exclusively in adults, and in 80% or more resides in the left colon at or distal to the rectosigmoid. It may be stalked, but is much more often flat and of large size. In one of the larger series, 1/3 were missed by the examiner's first digital rectal examination because of its soft texture and flat configuration. Proctosigmoidoscopy will reveal the tumor in most instances, but it will not usually reveal the concomitant presence of carcinoma within predominantly benign tumor. Missing a small island of carcinoma in proctoscopic biopsies, even if multiple, is disturbingly common. 55% of our patients with this lesion had an area of invasive carcinoma, and in 10 instances, the carcinoma caused the patient's death. 13 individuals had metastasis to regional nodes at the time of initial therapy. We have advocated total local excision of the villus lesion, along with an adequate area of normal mucosa. Even in large circumferential lesions, the technique suggested by Mark Hayes appears attractive to us. This is essentially the method of Rennes-Delaunay. It consists initially of thorough anal dilatation under caudal or spinal anesthesia. An attempt is made to prolapse the lesion to or through the anus with the aid of several retractors placed through the sphincter. One can then find a good cleft between the mucosa and muscularis in the submucosa, excise the lesion with 1 or 2 centimeters of normal mucosa on all sides, and perform a 2-layer closure. If the lesion is within 10 centimeters of the anal verge, this procedure can virtually always be accomplished successfully. It serves several purposes. If the specimen reveals invasive malignancy, an abdominal perineal resection can be performed. From other reported series, along with our own, carcinoma in situ, or surface atypicality, which occurs frequently in villous adenomas, is adequately treated by this wide local resection. Moreover, it provides for thorough microscopic cancer detection and will preclude the common problem of local regrowth, even if the lesion contains no malignancy. This plan of attack obviates an unnecessary abdominal perineal resection for a benign lesion. It may also be used for large adenomatous polyps of the rectum that cannot be removed completely through the proctoscope.
The last speaker on this symposium, Dr. John Spratt, has been introduced to you already in many respects. Dr. Spratt.
From the diagnostic standpoint, asymptomatic colonic polyposis is rarely, if ever, diagnosed unless it is visualized by endoscopy, barium, or barium-air contrast Röntgen studies, or by the anatomical pathologist on examination of colon removed by surgical resection or at autopsy. By each method of diagnosis, characteristics of the gross polypoid lesions and of the host exist that permit a presumptive diagnosis of the microscopic taxonomy and the probable behavior of the polyps if left untreated. The nature of the grossly diagnosed polyps is never known with certainty until biopsied sections are examined microscopically. The gross characteristics of polypoid lesions that can be measured or described are the number, the size, the shape, and the location. These gross observations have been combined with other host characteristics for the description of quite a variety of syndromes. When several gross measurements are recorded at different points in time, the mean rate of change in size that occurred between two measurement points can be estimated, giving still another set of parameters for taxonomy, namely the gross rates of growth. When the microscopic taxonomy is correlated with the gross rates of growth and the observed prevalence, it's been shown that the most frequent polyps are the scattered, slow-growing adenomatous polyps that increase in incidence with age, to the point that 40 to 60% of the people have these lesions near the terminus of the lifespan. Though frequent, many of these lesions never reach a symptom-producing size during the human lifespan. By comparing the fastest observed growth rate for a proven cancer to the average remaining lifespan, it can be stated that in most cases, few persons past age 85 merit exhaustive diagnostic evaluation of the colorectum if they are asymptomatic. And I think this is an important figure. The previous speakers have commented on the age 40 to 45 when people begin to become at risk, but I think it's also important to realize that there gets to be a point of time when the risk again becomes relatively low, and the very elderly should be spared exhaustive diagnostic evaluation. Most benign colonic polyps grow even more slowly than do the cancers, and many have been observed to regress on serial Röntgen observation. Furthermore, elderly persons are less tolerant to the occasional complications of proctosigmoidoscopy and barium enema. Infrequent colonic polyps that have been observed on sequential barium enema show a variable pattern. See occasional infrequent polyps such as amyloid tumors, inflammatory polyps, leiomyomas, lipomas. Simple normal mucosa can fool the radiologist from time to time. Retention polyps. These have variable patterns of growth and are an occasional source of confusion. Because of the correlation between the presence of cancerous morphology and colonic philic defects that, as previous speakers have pointed out, are frequently polypoid or sessile initially, and the faster rate of growth, the cancers are much more likely to attain a significant mass during the normal human lifespan. Consequently, size of a colonic filling defect of a polypoid nature is a highly significant variable. And on the basis of size alone, on radiographic shadows, we can come up with a presumptive diagnosis of cancer with this probability. To find very small cancers of small size, you would have to go to the basic incidence rates, and you would expect to find no more than several per thousand. By the time you get to polypoid filling defects or intercolonic filling defects that are more than a centimeter in size, on first examination, you are dealing with an incidence of cancer among those filling defects that's 14%, and this increases progressively with increasing size. By the time you get to lesions that are over 2 centimeters in size, some 2/3 of those will indeed be carcinoma. So size is a significant characteristic, and radiographically diagnosed polyps larger than 1 to 2 centimeters and greatest caudal dimension usually merit laparotomy because the chance that the larger polyps are indeed cancers exceeds the risk of laparotomy. Multiple polyposis of the large intestine and rectum is a gross diagnosis. On the basis of age, family history, and other syndrome-specific variables, a presumptive diagnosis may be made regarding the histological composition of the polyps. However, final diagnosis cannot be made in the absence of a biopsied polyp. Types of multiple polyposis encountered include familial adenomatous polyposis, Poits-Jeghers polyposis, when the colon's involved, lymphoid polyposis, juvenile polyposis, inflammatory polyposis, lipomas. All of these things can produce polyposis, and you only know what type you're dealing with when you have a histological examination of a representative polyp. The prognosis and method of management varies with each type. Both overtreatment and undertreatment can result from failure to make judgment decisions intended to minimize adverse host effects under various circumstances. Types of multiple polyps occurring mainly in young persons are juvenile polyps and lymphoid polyps. The latter require no surgical intervention. The absolute indications for surgical intervention to alleviate and prevent adverse host effects of juvenile polyposis include rare cases of intestinal obstruction, usually associated with intussusception, persistent symptoms of intermittent intestinal obstruction or colic, and the very rare diagnosis of coincidental cancer. I have not seen this personally. In each surgical operation for juvenile polyposis, conservatism is in order. The simplest operation that will totally remove the troublesome polyps is the preferred treatment. These polyps are not neoplastic and could be either allergenic or hamartomatous in origin. Poits-Jeghers polyps involve both the small and large intestine. These cases are at risk of being overstudied from the standpoint of diagnostic radiology and overtreated from the standpoint of resective surgery. I have seen both problems associated with Poits-Jeghers syndrome, including malabsorption syndrome from the resection of excessive length of the intestinal tract. Consequently, the evaluation and treatment is restricted to the symptomatic. By educating patients into their disease, they will make the logical demands for service required. Intermittent colic almost always precedes crisis episodes of intussusception by a time interval adequate for effective treatment. The relation between Poits-Jeghers polyps and cancers is doubtful. Consequently, extensive resections in the name of cancer prevention is not an acceptable rationale of practice. The rationale in the last analysis has to be based on a series of clinical management reviews, on epidemiological studies, and on the extant data that we have. You need a variety of clinical management information based on the experience in your own institution, including age-specific annual mortality of cancers arising de novo, arising in polyps, the age-specific incidence rates of polypoid lesions, false negative diagnostic rates, false positive diagnostic rates, morbidity and mortality rates of diagnostic effort, morbidity and mortality rates of therapeutic efforts, rates of growth, the critical size that produces adverse host effects, age-specific man-years of life remaining, the availability of clinical skills necessary for a good control program. All of this information has to be integrated into a system of logic that becomes the rationale of practice.
Thank you, gentlemen.
The conclusion of the panel discussion on the management of polypoid diseases signals the end of Side A of this program, Doctor. Side B can be heard by just flipping over the cassette or 2 reels on your tape recorder. This is Side B, Audio Digest Surgery, Volume 18, Number 13, continuing the first of a 2-part program on management of colon and rectal cancer and polyps. Once again, our program chairman, Warren H. Cole.
The first paper in this part of the program is on the management of the patient with familial polyposis of the large bowel by Dr. Charles Mortel, Associate Professor of Medicine, Graduate School of Medicine, Rochester. Dr. Mortel.
The clinical nature of multiple polyposis is quite clear, and indeed it's also appeared that the proper management of multiple polyposis is well established. The majority of opinion has placed subtotal colectomy with ileorectosigmoidostomy as the procedure of choice. This followed by fulguration of rectal polyps and frequent proctologic surveillance thereafter. There were 203 patients who had subtotal colectomy and ileorectosigmoidostomy for multiple polyps of the large bowel at the Mayo Clinic prior to May of 1963. Now, we eliminated patients who died in the immediate postoperative period, those who had known carcinoma in the retained rectum, and those with juvenile or Poits-Jäger's type polyps. And there remained 178 who could be potentially followed for more than 6 years. Only one of these was lost to follow, and he only after 11 years. Among these 178 patients, there were 35 who had had no polyps in the rectum, either prior to or at the time of surgery. Now, in comparing these patients to those who presented with diffuse polypoid disease in the rectum, we seem to be dealing with 2 clinically distinct disease processes. In the group with no rectal polyps, the patient presented at a more advanced age. There were considerably more men than women, and only 1 patient gave a positive family history. In contrast, patients with diffuse polyps in the rectum presented at a much younger age. They were equally distributed as to sex, and the great majority had a positive family history. Patients with only scattered polyps in the rectum seemed to fall in the middle of this spectrum. Well, in this first group of patients with no initial polyps in the rectal segment, none has developed a rectal carcinoma during the total follow-up period of 304 patient years. It would appear that if any predilection to rectal carcinoma exists in these patients, the magnitude is small, and subtotal colectomy with ileorectosigmoidostomy would seem to be justifiable. Well, the remainder of this presentation will concern the much larger group of 143 patients who had multiple polyposis involving the entire large bowel, including the rectal segment. During our follow-up period, a total of 31 of these patients, or 22%, have developed proven invasive rectal adenocarcinoma. Now, whereas this figure is impressive, it's not truly reflective of the eventual cancer potential, since many of these patients have been followed only a very few years. During the initial few years, the incidence is quite low. After 10 and 15 years, however, it rises rapidly. And by 23 years, almost 60% have developed cancer in the retained rectum, with the occurrence rate continuing to rise. Well, these figures are in some measure artificial, since they're related to the time chosen for surgery, which in many instances may be arbitrary. Probably a truer picture of the cancer risk in the retained rectum can be obtained by comparison to the expected age-specific occurrence in the general population. For this purpose, we related the occurrence of rectal cancer during 1,785 follow-up years of observation in our patients to the corresponding age-specific incidence observed in the general population by the Connecticut and Alameda County tumor registries. The ratio of observed rectal cancers in our study to that expected by tumor registry data is 100:1. The sex of the patient had a pronounced influence, with the female showing a several-fold increase over the male. The presence of carcinoma in the resected colon and the number of polyps in the rectum at the time of initial diagnosis also had a striking influence on the frequency of subsequent rectal carcinoma. For otherwise comparable patients, a positive family history of multiple polyposis did not have a detectable influence on the incidence of cancer. We've documented the characteristics of the patient group developing carcinoma in the retained rectum. Female patients were predominant. The median age at diagnosis of rectal cancer was 48 years, approximately a decade earlier than might be expected in the general population. The interval from ileorectosigmoidostomy to diagnosis of carcinoma was a median of 10 years. Of considerable significance is the fact that the median interval from the last proctoscopic examination to the diagnosis of rectal carcinoma was just 6 months. Only 2 of these patients were negligent. The remainder had faithfully reported for regular examinations and fulguration of all rectal polyps. Now, these facts would seem to belie any suggestion that fulguration of rectal polyps is an effective preventative for carcinoma. Indeed, the heretic would speculate with equal justification that this repeated injury to the rectal mucosa could in itself be carcinogenic. Well, this data must also make one wonder about the true effectiveness of detection and fulguration of rectal polyps as a means of cancer prevention for the general population. Very disturbing are the poor surgical results in our patients who developed carcinoma in the retained rectum. Only 6 of 25 followable for more than 5 years are living without evidence of malignant disease. This in spite of the early diagnosis afforded by frequent proctoscopic examinations. One likely reason for this would appear to be the frequency with which early invasive cancers were initially managed by fulguration, either with or without radium application. Out of 12 patients so treated, fulguration was successful in only 3. Those remaining had uncontrolled cancer, which eventually was treated by resection, but at a much less favorable stage of the disease. It must be emphasized that those chosen for fulguration had small, freely movable, early invasive lesions for which prompt surgical treatment should have been curative in nearly all. In the patient of reasonable operative risk, fulguration should have no place in the curative management of invasive carcinoma of the rectum. Well, one of the arguments raised against the alternative of total proctocolectomy has been the complications associated with a permanent ileostomy. And indeed, these are very real, although they have been substantially reduced with modern surgical techniques. Well, not fully realized, perhaps, is the potentiality for complications with a subtotal colectomy and repeated fulguration of rectal polyps. Beyond a postoperative death rate comparable to that of elective total colectomy, these patients also have a significant incidence of major and sometimes fatal late complications. And these do not include the still more frequent mild to moderately severe problems of persistent diarrhea or bleeding following fulguration. Well, another argument raised against total colectomy for multiple polyposis has been the emotional impact of a permanent ileostomy. Now, this, of course, cannot be discounted. But in our experience, the vast majority of patients can make an excellent emotional adjustment to this anatomic change. The patient treated with subtotal colectomy and ileoproctostomy, in addition to the major operative procedure, must then face the discomfort and expense of multiple proctologic procedures immediately following the surgery, as well as frequently and indefinitely thereafter. The patient who has seen family members die of bowel cancer, as many have, knows that this sword hangs constantly over his head. Added on to all this, the majority of these patients must later undergo the risk, disability, and expense of yet another major surgical procedure, and then face the same emotional trauma from which they were allegedly being protected, compounded now by the fear of recurrent cancer. Above all others, however, one consideration must be dominant. The course of patients with subtotal colectomy and ileoproctosigmoidostomy has made it obvious that this procedure, plus periodic fulguration of rectal polyps, does not prevent the development of large bowel cancer. Since prevention of cancer is the primary objective of surgical treatment of multiple polyposis, procedures which allow retention of the cancer-prone rectal mucosa must be discarded as therapeutically inadequate. Unless a role can be established for ileal pull-through procedures, this must mean surgical excision of the rectum. Now, a gray zone exists in those patients found initially to have only a few rectal polyps. And here there is room for clinical judgment based on age and sex of the patient and the presence or absence of carcinoma in the colon. For the typical multiple polyposis patient, however, who has myriads of polypoid lesions studding the rectal mucosa, total proctocolectomy with permanent ileostomy should be the procedure of choice.
Next presentation is on the techniques for the surgical management of colonic cancer by Dr. Mouse Stearns, attending surgeon, rectal and colon service, Memorial Hospital, New York. Dr. Stearns.
The colon and rectal service at Memorial Hospital is composed of a group of surgeons, almost all of whom limit their practice largely to the treatment of patients with cancer of the colon and rectum. This group is responsible for the training of surgical residents who rotated through the services for periods of 2 to 3 months. These residents do all the ward surgery under direct supervision of one of the service attendants. In evaluation of the techniques for treatment of cancer of the colon used by this group, we have discussed at length the details of procedures in order to arrive at accepted common denominators that have been used in the treatment of our patients. The results obtained between 1949 and 1959 have been compiled by Dr. David Schottenfeld, the co-author of this review. Preoperative preparation. During the years under discussion, the preparation for surgery for patients with cancer of the bowel were saline catharsis. Clear liquids only were given for 2 days preoperatively. Plain tap water enemas were given daily. Antibiotics were not used. Extent of resection. The most important common denominator in technique was the extent of resection. Individuals, by their own particular method, strove to accomplish wide removal of the mesentery of the bowel down to its base along the superior mesenteric and its branches, or the inferior mesenteric vessels. To accomplish this wide removal of the mesentery, some used a meticulous dissection to the root of the mesentery, exposing both the superior mesenteric and the inferior mesenteric vessels, regardless of whether a right or left hemicolectomy was done. The vessels were divided. Some utilized transillumination when feasible to visualize the vascular tree as high as possible, while others have simply dissected the mesentery as close to the origin as they could. Tumors of the cecum or ascending colon were treated by right hemicolectomy, including, for cecal lesions, the terminal 12 inches of the ileum, with ligation of the vessels going to the portion of the colon as they arose from the superior mesenteric vessels. This included either the entire mid-colic or the right branch of the mid-colic, as indicated. Treatment of lesions of the proximal transverse colon was by an extended right hemicolectomy, often to the mid-descending or sigmoid colon, depending on anatomic variations. Lesions of the splenic flexure or descending colon were treated by left hemicolectomy with inclusion of the mid-colic vessels for the more proximally located lesions, or the inferior mesenteric for the more distally located tumors. Tumors of the sigmoid were usually treated by segmental resection of the redundant loop with the mesentery to the origin of the inferior mesenteric. If the tumor was proximal or there was a short loop, a left hemicolectomy was performed. With any intraperitoneal colon cancer, the omentum was removed with a specimen. Any adherent small bowel or other viscus was resected with a specimen and not dissected free. Protection from contamination. All used reinforced double-thickness laparotomy pads to protect the entire thickness of the abdominal wall. Similarly, after exploration, adjacent viscera, particularly small bowel, were protected by packing with laparotomy pads in such a way as to isolate the operative field. Some covered the tumor, others did not. All washed their gloves frequently and changed gloves and drapes before entering a clean field. Manipulation. All explored the abdomen thoroughly before approaching the region of the tumor. The adjacent viscera were protected by laparotomy pads before the tumor was palpated. All palpated the tumor to determine operability or any other problem that might influence treatment. All stressed the minimal manipulation of the tumor, insisting on traction of the distal or proximal bowel rather than on the tumor itself. However, all mobilize the bowel and tumor prior to ligation of the vessels to effect maximum removal of the mesentery. Intraluminal spread of cancer. Some decide the site of bowel transection early in the procedure before manipulation is done, applying intestinal clamps to be used later for division. Most do not make any attempt to occlude the lumen until they are ready to transect it. After transection of the bowel, all carefully excise the crushed ends. All suction both ends of the lumen before starting the anastomosis. And most swab the open ends, the distal 2 inches, with tincture of Zephyrin, liberally. Following resection of the tumor, about half irrigated the tumor bed, usually with distilled water. After placement of drapes, laparotomy pads for initial protection, these are not removed until the resection has been completed. However, gloves were washed frequently during mobilization and resection. Some change gloves and add fresh drapes before doing the anastomosis. Others wait until the anastomosis has been completed, then removing all the drapes, changing gloves before closing the abdominal wall. The anastomosis was generally done with 2 or 3-0 atraumatic chromic catgut. Silk was used for the outer layer.
At the ACS conference, the Mayo Clinic's Lloyd G. Bartholomew focused on unusual systemic manifestations that may lead to early diagnosis of colonic cancer. Prompt recognition of these manifestations, which sometimes appear months before the tumor becomes evident, will help to ensure early treatment and, occasionally, to prevent further growth of the lesion. Dermatologic manifestations are often so obvious that they're overlooked. Patients with Gardner syndrome, a genetic disorder related to familial polyposis of the colon, may present complaining of a hard mass in the jaw. Characteristically, they have bony outgrowths, osteomas or osteochondromas, on other facial bones or the long bones. Look for polyposis of the colon, the speaker advised, and with this, adenomas, fibromas, and occasionally desmoid tumors. Dermatomyositis can occur before, coincident with, or after the recognition of colonic cancer. Be especially suspicious when dermatomyositis develops in a man over 40. This condition is characterized pathologically by muscular inflammation, clinically by muscular weakness and tenderness. Dermatologic manifestations can be subtle or florid and include a pinkish or violet skin color and atrophic changes in exposed areas like the face, neck, or upper arms. Acanthosis nigricans may precede the recognition of a tumor by months to years. Characteristic signs are elevated wart-like lesions and hyperpigmentation occurring in flexural areas. Be suspicious, Dr. Bartholomew advised, when acanthosis develops in patients over 40 and the lesions are pruritic and progressive. Herpes zoster is probably not significant unless the patient is already ill when it develops. Then there may be underlying disease, possibly GI cancer. Some patients with colonic cancer develop endocrine manifestations, like Cushing syndrome, though not the classical florid variety. These patients tend to lose weight rather than to gain weight. They have marked muscular weakness and wasting, and most characteristically, an unusually low serum potassium, refractive to treatment. Large doses of dexamethasone often fail to suppress the ectopic secretion, an important point in the differential diagnosis. An underlying tumor should always be considered when Cushing syndrome develops in a male over 50. Symptoms in patients with hypoglycemic-producing colon tumors vary from hypoglycemic episodes after a patient misses a meal to intractable hypoglycemia. The lesions tend to be large, 2 to 10 kilograms, making surgical removal difficult. The carcinoid syndrome also occurs in patients with colonic tumors, though it's more common with lesions of the small intestine. The most revealing systemic clue is flushing. Extreme weakness and lethargy in a patient with hypercalcemia should arouse suspicion of colonic cancer without metastases. The condition can be differentiated from hyperparathyroidism, the speaker pointed out, by the presence of anemia, weight loss, and excessively high serum calcium levels. Recurrent thrombophlebitis is a common vascular manifestation and may be the earliest indication of cancer. It's an ominous sign, though, because it means metastases have already occurred. Be suspicious, the speaker warned, when patients over 50 develop thrombophlebitis for no reason and are not responsive to anticoagulant therapy. Other helpful signs are anemia and an elevated sedimentation rate. Lymphedema may result from malignant occlusion of the pelvic lymph vessels and occasionally means lymphatic spread. It's characteristically silent with the exception of the swelling and involves only one leg. Acute digital ischemia may occur because of small arterial occlusion. Initial symptoms are persistent cyanosis or recurrent Raynaud's phenomenon in the presence of normal peripheral pulses. The abrupt onset of symptoms in a middle-aged patient should make you suspect cancer, Dr. Bartholomew advised. Two common rheumatic and joint syndromes are hypertrophic osteoarthropathy, Mary Bamberger's disease, and a rheumatoid arthritis-like syndrome. Although not common, colonic tumors do cause hypertrophic osteoarthropathy. Symptoms include the abrupt development of clubbing, thickening of the periosteum or periostitis of the long bones, synovitis, and burning paresthesias. In patients with rheumatoid arthritis-like syndrome, special features suggest an underlying tumor, late onset, over age 50, and an unusual pattern or distribution of joint involvement. Summing up, Dr. Bartholomew noted that atypical features of any of these systemic manifestations should arouse suspicion, and an underlying colonic lesion must be ruled out as the cause.
Now we'll proceed to the last discussant, management of carcinoid tumors by Dr. Marshall Orloff, Department of Surgery, University of California, San Diego. Dr. Orloff.
Since our first report on carcinoids of the rectum some 12 years ago, considerable experience with this unique tumor has developed. Somewhat over 600 cases of rectal carcinoid have been reported in the literature. Today, I propose to summarize these recent developments and to review our own experience with 38 carcinoids of the rectum treated more than 5 years ago. Carcinoid tumors originate from one or another of several types of enterochromaffin cells and have clinical, histochemical, and biochemical differences related to their sites of origin. While metastatic carcinoids arising from the foregut and midgut structures secrete a variety of potent humoral agents in addition to serotonin and are associated with various clinical disturbances that collectively are called the malignant carcinoid spectrum, rectal carcinoids do not secrete any physiologically active substances and do not produce the malignant carcinoid spectrum. Carcinoids of the rectum occur most frequently in the 6th and 7th decades, usually appear as submucosal nodules, and often are asymptomatic, although some are associated with mild rectal bleeding, constipation, and rarely with obstructive symptoms. Microscopically, carcinoid tumors of the rectum appear benign according to the usual cytologic criteria. There really is no way on cytologic grounds of predicting the likelihood of metastases from their microscopic pattern. However, as we proposed in our initial report 12 years ago, the size of the tumor and microscopic evidence of invasion into and beyond the main muscle coat of the bowel show a good but not perfect correlation with the presence of malignancy. 23 patients in our group had neoplasms that measured less than 2 centimeters in greatest diameter. Only one of these tumors, a lesion that measured 1 centimeter in diameter, was found to have involved the muscularis of the bowel and subsequently was found to have spread to the regional nodes. In contrast, 15 of our patients had tumors that measured 2 centimeters or more in greatest diameter. 13 of these 15 neoplasms showed microscopic evidence of muscle invasion. 12 of them had spread to the regional lymph nodes, and 6 of them had metastasized to distant organs. All patients with lymph node metastases had neoplasms that invaded the muscularis. One of our patients had distant metastases without evidence of either muscle or lymph node invasion. Thus, a tumor that is less than 2 centimeters failed to reflect benign disease in only 1 of 23 of our cases, and a tumor diameter greater than 2 centimeters or 2 centimeters or greater was not associated with malignant disease in only 1 of 15 of our cases. Similarly, microscopic evidence of invasion of muscle was not associated with lymph node metastases in only 1 of 14 cases, and lymph node metastases were invariably associated with tumor invasion of muscle. In the overall, 15 of our 38 patients, or 39%, had invasive carcinoid tumors that were considered malignant. In the evaluation of patients with rectal carcinoids, the importance of obtaining an adequately deep biopsy to make a judgment about muscle invasion and of carefully measuring the size of the tumor cannot be overemphasized. Because of their location, carcinoids of the rectum present particular problems in treatment. If they are benign, all that is required is a relatively minor local excision. On the other hand, if they are malignant, a radical extirpation, usually consisting of an abdominal perineal resection with permanent colostomy, is mandatory. Therefore, the decision about benignancy or malignancy is really a crucial one, which has far-reaching implications as to the life and comfort of the patient. In 1959, we proposed that lesions smaller than 2 centimeters in diameter, which did not invade muscle, could be treated by local removal. Contrariwise, we suggested that tumors which measured 2 centimeters or larger in diameter, or which showed invasion of muscle on biopsy, or which recurred after local excision, required radical resection. Our continuing experience with rectal carcinoids, as well as the experience of others, has substantiated the validity of these therapeutic criteria. This was the results of the application of these therapeutic principles to our 38 patients with rectal carcinoids, all of whom were followed for more than 5 years after treatment if they survived. 23 patients had tumors smaller than 2 centimeters in diameter. In 21 of these, there was no evidence of tumor invasion of muscle, and the lesion was removed by one of several techniques of local excision. 2 of these patients in the small group underwent abdominal perineal resection, one because of the finding of muscle invasion, and I might say subsequently this proved to be associated with lymph node invasion as well, and the other because of an associated polypoid adenocarcinoma of the rectum. The tumor that invaded the muscle was smaller than 1 centimeter in diameter. All 23 patients with carcinoids smaller than 2 cm survived for more than 5 years without recurrence. 15 patients had rectal carcinoids that measured 2 cm or greater in diameter. One of these, a 76-year-old man who had a 2 centimeter lesion that did not invade muscle, was treated by local excision and survived without recurrence for 10 years. Another patient had liver metastases in the absence of muscle invasion, and she received palliative therapy. The remaining 13 patients with tumors 2 centimeters or larger had muscle invasion by the tumor. 8 of the 13 received radical treatment in the form of an abdominal perineal resection in 7 and an anterior resection in 1, and 5 survived more than 5 years free of disease. 5 of the 13 were given palliative treatment because their tumors had metastasized at the time that they were first seen, and all of them died of metastatic carcinoid, 4 within 2 years of treatment, and the other 9 years after discovery. The 5-year survival rate of the 15 patients with lesions measuring 2 centimeters or greater in diameter was 40%, in contrast to the 100% 5-year survival rate of the 23 patients with lesions measuring less than 2 centimeters in diameter. In the overall, the 5-year survival rate of this group of 38 patients was 76%.
Thank you very much. The meeting is adjourned.
Next week, part 2 of the session, discussions on preoperative irradiation and preparation of the colon, surgical techniques, chemotherapy, and prevention of recurrences. Audio Digest Surgery is produced and copyrighted twice each month by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association.